Good evening, Dr. Khanna. Thank you once again for this wonderful invitation. And thank you, Dr. Mahapatra. I will just share the screen now. So today I'll just be talking about the concept and understanding of CMR and giving you a few interesting cases. In 15 minutes, we'll just try to get a snapshot of what the cardiac MRI can do. So why MRI? And you've just heard Dr. Mona very beautifully talking about the various modalities. And if you look at the various facets of cardiac disease, the morphology, the function, the tissue, and the metabolism, you will see that the CMR covers all of them in a very, very comprehensive manner. Although there are pros and cons with each technique, but MRI seems to have most of them under its wing. The technique, the preparation is actually none. Patients can come in, fasting is not required. As long as the GFR is above 45 mLs, there is no problem. There is no special preparation that has to be done like a PET scan, and sugars don't have to be controlled. So it's a very, very doable technique, and it can just be done very quickly. The positioning is important. ECG leads, we use the graphite leads instead of metal because of the magnet. And you need to get a good signal because the RR interval is very important to pick up the signals. Breath holding is very important, and we like to coach these patients usually at least a day before, if it's an elective patient, to hold their breath for 5 to 10 seconds so that you get some very good pictures. We have some navigator sequences that we use occasionally, but nothing like a good breath hold by the patient. There are three main sequences that we use, that the Cine sequence, the T1, T2 maps, and the inversion recovery for delayed hyperenhancement. The contrast is gadolinium, which is an extracellular contrast. We use it at a dose of 0.1 millimole per kg, 15 to 20 ml for an average size adult. The field homogeneity is very important. So when we put the patient in the magnet, we want to get the heart right in the center so that the homogeneity is preserved. We move from the body axis to the cardiac axis, which is a little different. So the coronal sagittal axial then gets modified. And this is a basic algorithm of what we do right from the body axis, and then we move to a partial two-chamber, four-chamber, the short axis, and then we get the three standard workhorse views, which we call the short axis view, the horizontal long axis, which also is called the four-chamber view, and the vertical long axis, which is the two-chamber view. We also do a series of axial haste views, which gives a lot of information about the morphology, gives an idea about the mediastinum, the nodes, the diaphragm, all these things which go along with pathologies of the heart. Then the ascending and arch is again formed. You can see that. And then most importantly, the MR is a gold standard for the RV pathologies. And on the four-chamber view, we plan out and we get the inflow, the body, and the outflow. And this is very, very important, especially in congenital heart disease. Now, the top 5 indications in CMR are the advanced ischemia detection, both for wall motion, ischemia, and scar tissue. Heart failure, again, MRI is almost like a gold standard, and there are very few other techniques that really competes. In the realm of electrophysiology, both for the planning and follow-up of patients post AF and VT ablation, MR again is a very, very important tool and is being used increasingly in electrophysiology labs. It is a gold standard for cardiac function, especially the right heart function, and also used in patients with pre and post transplant. Congenital heart disease is a huge thing by itself, and cardiac MRI is turning out to be a very, very important player in that segment, especially for complex congenital heart disease and patients who have very poor echo windows and patients who need intervention. The cardiac MR is a very important tool. Now, the most important feature of the cardiac MR is in heart failure, where you're looking at the ejection fraction. We know that the low ejection fraction, less than 45, has a poorer prognosis than higher ejection fraction. So it's very, very important to get that number right. The ejection fraction also is a very important tool which plays before you put in a device and prognosticate the patient. So with the cardiac MRI, you will see with the 8 slice data that we have using the Simpson's technique, we get a very, very good ejection fraction, mass, the volumes, and the cardiac output. And this is has got very less inter-observer variability, and also can be done again and again with very low variability. Diastolic dysfunction in heart failure, preserved ejection fraction, again, is a very important thing, and the grid imaging is a sine qua non to the strain imaging and echo, and the displacement of individual grids gives an element of the intrinsic myocardial contraction. LA volume, again, a very important part of diastolic function, can be planimetered very, very well without any window issues. And it's a very reproducible function. The second important facet is whether the patient has coronary artery disease or not. And if you look at Felker's data, you clearly can see that the patients with ischemic subset have a poorer prognosis in heart failure compared to the non-ischemic. So the traditional way to assess this was to do the coronary angiograms. As you can see, the one on the left has a normal angiogram, and here there is a total LAD cutoff. However, the cardiac MRI can do the same job, albeit in a non-invasive fashion. And based on the delayed enhancement, this is post-gadolinium, you can see here that the ischemic subset has a subendocardial scar here and here, whereas the non-ischemic subset, and there are many, and I will be touching upon a few, have what is called a mid-myocardial scar. The only disease which comes very close to the ischemic subset is amyloidosis, and that can be easily seen clinically. And also here you can see the subendocardial scar is global, does not respect any vascular territory. So this is what cardiac MRI is, and this is the kind of workhorse that it is, that it looks at so many of the contemporary cardiac diseases that we work with day in and out. So coming to coronary artery disease, you can see that the first step in coronary artery disease is the wall motion abnormality, and you can see that this is stacked very well. And once you have the wall motion and also the ejection fraction, we move on to the rest myocardial perfusion. And here you can clearly see that the LAD territory is involved. And then we move on to the delayed hyperenhancement. And you see the gadolinium enhancement here, again in the LAD territory. And once you have all the three data fused together, you get a data set like this with the wall motion, you get the gadolinium enhancement, and finally, you put both of them together and you get the viability assessment. The pink obviously is the non-viable areas. These are areas which have been akinetic. These are the areas which are more than 50% gadolinium, and they will show up as non-viable. Whereas the patients who have a normal wall motion or mildly hypokinetic with mild gadolinium enhancement of less than 25 would be the viable and hibernating myocardium. So a very simple and easy way to depict viability in patients with COD. The second group is the patients with where we need to do reconstructive techniques, especially those with aneurysms. And the MR really gives us a lot of data on the presence of clot, the volume of the aneurysmal segment, the volume of the remnant LV, and helps surgeons to perform these procedures. Moving on to valvular heart disease, the role of MRI again has, for the first time in 2017, been clubbed with the American Society of Echo, and both the societies together gave these guidelines. A very important function in aortic valve disease, where you can do a very good planimetry, and especially in diseased, very calcified valves, it's a real boon and really adds on to the information what echo can give. But it is really in the regurgitation lesions, you can see the magnitude, the structure of the valves, and also you can get a very, very clear assessment of the regurgitation volume and the regurgitation fraction, which no other technique can really surpass. Mitral stenosis, again, is obviously in the realm of echocardiography, but there are situations in which, because of a very deformed valve and difficult echo windows, the CMR has been used for planimetry, and you can see that there is a very good agreement with 2D echo. Mitral regurgitation, again, a very important clinical problem, and here you can clearly see not only the structure involved, the mechanism, and also you have a very clear way of assessing the regurgitant volume based on the aortic flow and the stroke volume, and also the regurgitant fraction. And these are very important indices for sending these patients early for surgery or for interventional procedures like the mitral clip. In pericardial diseases, no prizes for guessing this patient with a septal bounce and constrictive physiology. But what is more, it gives you also the thickness of the pericardium, and also gives you the enhancement of the pericardium, which is nothing but a pericardial inflammation. And these are patients who do well with a course of steroids before they end up under the surgeon's knife. In congenital heart disease, obviously it's a large area, but in adults, primarily we're looking at patients who have already been operated. There's a patient with the tetralogy, post-ICR, and we're looking for the RV volumes, the RV function, and also the pulmonary regurgitation fraction. Here you can see is almost 50% of the forward volume. And this is a patient where you would either do a percutaneous pulmonary valve or send the patient for a surgical procedure. Coarctation of aorta, again, in the adult, sometimes is difficult to visualize completely by the echo. And here you can see the flow. You can also look at the collaterals which are entering here, and that helps us to quantify the coarctation, especially if it is a borderline stenosis. And obviously, the contrast here helps the interventionist to know exactly where to place the stent. But it is really in the non-ischemic cardiomyopathy group wherein the role of MRI shines. We know that there is a huge number of diseases, and also the diseases are important because the prognosis of each disease is completely different. For example, peripartum has a very good prognosis compared to somebody with a HIV infection. And MRI is able to sort of really splice through and give us an idea about what these diseases are. What is also very important is the presence of gadolinium enhancement in blue really tells us the difference between the patients without it in terms of all-cause mortality, in terms of heart failure, hospitalization, and sudden cardiac death, and really enters the prognostic arena where it not only gives us morphology, but also gives us the prognosis. And again, this is the case of myocarditis. You have the wall motion, you have the edema here, and also you have the diffuse scarring, which is epicardial and not subendocardial. In a patient, a young patient who came with VT and also who came with recent history of fever. In patients with dilated cardiomyopathy, some of them actually have non-compaction, and here you can see the non-compaction very well displayed on the MR, and we follow the ratio of 2.3:1 in diastole compared with echo, which is in systole, and helps in taking out that subset of patients who can actually benefit with anticoagulation.
Sorry to interrupt, Dr.
Yes.
Christopher.
Yes.
Time is up. Please kindly conclude it.
Yes. So in sarcoidosis, again, the role of gadolinium helps in a big way. And if you add a PET scan to this, you will clearly see that when we started immunomodulators and steroids, there is a significant relief 3 years later. And this is a lot of work we've done on sarcoid. And what is important is that now the PET scan here below and the MRI are two distinct fields, but we have realized that we cannot do anything further unless there is a synergy. So you get a structure here on the MR in terms of the scar, and you get the functional assessment on the PET, and you can clearly see in a PET MR, you get both the benefits, both the scar as well as the functioning living tissue, making a great difference in terms of the management. Amyloidosis is another difficult disease, and the MRI really shines through and helps with the usage of drugs where you can actually see there is a disappearance of that scar tissue and the LV function really returns to normal. And with the addition of the T1 mapping and the ECV mapping, you can also get the diagnosis and, more importantly, the prognosis.